Welcome to the lecture on hypoxia and CO2 transport. This is from Chapter 6 and part of Pulmonary Anatomy and Physiology. I want to talk about hypoxia first. We're going to talk about the difference between hypoxemia and hypoxia. We'll start with hypoxemia. This means an abnormally low amount of oxygen in the blood. And many times hypoxemia is seen together with hypoxia, which is not enough oxygenation in the tissues. But they don't always go together. Although the presence of hypoxemia, low amounts of oxygen in the blood, strongly suggests tissue hypoxia, it doesn't necessarily mean there absolutely is tissue hypoxia. For example, a reduced amount of oxygen in arterial blood may be offset by an increased heart rate and increased stroke volume or increased cardiac output. Hypoxia, again, is a low or not enough oxygen for aerobic cellular metabolism. Hypoxia is characterized by tachycardia, hypertension, peripheral vasoconstriction, dizziness, and mental confusion. Let's start by talking about hypoxic hypoxia. Clinically, hypoxic hypoxia, also called hypoxia, refers to the condition in which there is not enough oxygen at the tissue cells caused by a low arterial oxygen tension, or P(a)O2. Common causes include a low alveolar oxygen tension, low P(a)O2, diffusion deficits, perfusion mismatches, and pulmonary shunting, either absolute or relative shunts. So let's start with low alveolar oxygen tension, or a low P(a)O2. Because the arterial oxygen pressure is determined by the alveolar oxygen pressure, any condition that leads to a decreased P(a)O2 will result in a reduction of the patient's P(a)O2. So, these will also result in inadequate content of arterial oxygen. Common causes of a low alveolar oxygen tension include not breathing enough or hypoventilation, and high altitudes, like someone climbing to the top of Mount Rainier. Hypoventilation can be caused by many chronic conditions, such as chronic obstructive pulmonary disease, central nervous system depressants, opioid overdose, head trauma, and neuromuscular disorders. Head injuries, myasthenia gravis, or Guillain-Barré syndrome. High altitude can cause hypoxic hypoxia to develop. This is because the barometric pressure progressively diminishes as altitude increases. So at the bottom of the mountain, you have normal barometric pressure, but at the top, you have a lower barometric pressure. So the higher an individual hikes up a mountain, the lower the oxygen pressure the person is inhaling, which in turn leads to a decreased alveolar oxygen tension and a decreased arterial oxygen tension. So let's talk for a minute about diffusion deficits. Diffusion deficits are abnormal anatomic alterations of the lungs that result in an impedance of oxygen to transfer across the alveolar capillary membrane. When a diffusion deficit is present, The time available for oxygen equilibrium between the alveolus and the pulmonary capillary is not enough. This condition is referred to as diffusion limited. There's something wrong at the lung. Causes of diffusion deficits include chronic interstitial lung diseases, pulmonary edema, emphysema, pneumonia, and alveolar collapse or atelectasis. Another reason is ventilation perfusion mismatch. Ventilation perfusion mismatch is when the pulmonary capillary blood is in excess of the alveolar ventilation. A decreased VQ ratio is said to exist when this happens. This condition causes pulmonary shunting, which in turn causes a low arterial oxygen attention and a low content of arterial oxygen. Common causes of decreased VQ ratio include chronic obstructive pulmonary disease, pneumonia, and pulmonary edema. The effects of different VQ relationships will be discussed in great detail in a coming video. Pulmonary shunting is the result of moving deoxygenated blood bypassing the pulmonary system and taking it to the left side of the heart. Venous admixture is the result, and it becomes a decreased PaO2 or a decreased low arterial oxygen tension. It also results in a decreased content of arterial oxygen. Next, anemic hypoxia. In this type of hypoxia, the oxygen tension in the arterial blood is normal, but the oxygen carrying capacity of the blood is low. This form of hypoxia can develop from two things: not enough hemoglobin in the blood, or a deficiency in the ability of the hemoglobin to carry oxygen, like carbon monoxide poisoning or methemoglobemia. Anemic hypoxia develops in carbon monoxide poisoning because the affinity of carbon monoxide for hemoglobin is about 210 times greater than that of oxygen. As carbon monoxide combines with hemoglobin, the ability of hemoglobin to carry oxygen diminishes, and tissue hypoxia can result. In methemoglobemia, iron atoms in the hemoglobin are oxidized to a ferric state, which in turn eliminates the hemoglobin's ability to carry oxygen. Increased cardiac output is the main way to compensate for anemic hypoxia. Let's talk a little about circulatory hypoxia, or stagnant. It's also called stagnant or hypoperfusion hypoxia. In circulatory hypoxia, the arterial blood that reaches the tissue cells may have a normal oxygen tension and content, but the amount of blood, and therefore the amount of oxygen, isn't enough to meet tissue demands. The two main causes of circulatory hypoxia are a slow or stagnant peripheral blood flow and arterial venous shunting. Hypoperfusion states can occur when the peripheral capillary blood flow is slow or pools. This condition can be caused by a decreased cardiac output, vascular insufficiency, or neurochemical abnormalities. I want you to think about a big overstretched heart. that's lost all its elasticity. It's not the size of your fist anymore, but the size of almost your whole chest. That kind of heart can't put out 70 cc's per beat. It can't even beat at 70 beats per minute. All it can do is put out a little bit. That left ventricle can only pump a little bit because it just can't contract enough. When arterial blood, so that's stagnant. But let's talk about when arterial blood completely bypasses the tissues and moves into the venous system. An arterial venous shunt is said to exist. This condition can cause tissue hypoxia because arterial blood is prevented from delivering oxygen to the tissue cells. Localized arterial or venous obstruction can cause a similar form of tissue hypoxia because the flow of blood into or out of tissue capillaries is impeded. An example of an arterial venous shunt is when there is a hole between the atrium and blood moves from the right side of the heart directly to the left side of the heart. The next type of hypoxia that we'll talk about is histotoxic hypoxia. Histotoxic hypoxia develops in any condition that impairs or disrupts the ability of tissue cells to utilize oxygen. Cyanide poison produces this form of hypoxia. Clinically, the PaO2 or arterial oxygen tension and the content in the blood are normal, but the tissue cells are extremely hypoxic. And the mixed venous oxygen tension and content and saturation are elevated because no oxygen is getting taken up by the tissues. Cyanosis. When hypoxemia is severe, signs of cyanosis may develop. Cyanosis is a term used to describe the bluish-gray or purplish discoloration seen on the mucous membranes, fingertips, toes, around the face, around the mouth, whenever the blood in these areas contains at least 5 grams per deciliter of reduced hemoglobin. When the normal 14 to 15 grams per deciliter of hemoglobin is fully saturated, the PaO2 will be about 97 to 100 millimeters of mercury, and there will be about 20 milliliters per deciliter of oxygen in the blood. In a patient with cyanosis, with 1/3 of the hemoglobin reduced, the PaO2 will be about 30 millimeters of mercury, and there will be only about 13 milliliters per deciliter of oxygen in the blood. You can see that pictured here. Overall, the hemoglobin is still about 60% saturated, even in cyanosis. So let's talk about how carbon dioxide is transported to the lungs. An understanding of carbon dioxide transport is essential to the study of pulmonary physiology and the clinical interpretation of blood gases. At rest, metabolizing tissues consume about 250 milliliters of oxygen and produce about 200 milliliters of carbon dioxide every minute. The newly formed carbon dioxide is transported from the tissues to the lungs in 6 different ways. 3 of them are located in the plasma and the liquid part of the blood, and 3 are at the red blood cell. We'll start by talking about how it's transported in the plasma. In the plasma, it's transported in 3 different ways: carbamino compound, or bound to protein, bicarbonate, and dissolved CO2. Although relatively insignificant, about 1% of CO2 just dissolves in the plasma and chemically combines with protein or amino groups. This forms a carbamino compound. About 5% of carbon dioxide dissolves in the plasma and ionizes as bicarbonate. Initially, carbon dioxide combines with water in a process called hydrolysis. The hydrolysis of CO2 and water forms carbonic acid. You've heard about carbonic acid before. This, in turn, rapidly ionizes into bicarb and hydrogen ions. The resulting hydrogen ions are buffered by plasma proteins, and the rate of this hydrolysis reaction in the plasma is super slow, and therefore the amount of bicarb and hydrogen ions that form from this is relatively small. There's also dissolved carbon dioxide in the plasma, and that accounts for about 5% of the total CO2 released at the lungs. In red blood cells, CO2 is carried as dissolved CO2, carbamino, hemoglobin, and bicarbonate. Dissolved carbon dioxide in the intracellular fluid of the red blood cells accounts for about 5% of the total carbon dioxide released at the lungs. About 21% of the carbon dioxide combines with hemoglobin to form a compound called carbamino hemoglobin. Most of the carbon dioxide, about 63%, is transported from the tissues to the lungs in the form of bicarbonate. The major portion of dissolved CO2 that enters the RBC is converted to bicarbonate by the following reaction. Carbon dioxide plus water with carbonic anhydrase goes to carbonic acid, which in turn goes to hydrogen ion and bicarbonate. This reaction, which is normally a super slow process in the plasma, is greatly enhanced at the RBC by the presence of carbonic anhydrase, an enzyme. The resulting hydrogen ions are buffered by reduced hemoglobin. The rapid hydrolysis of carbon dioxide causes the RBC to become saturated with bicarbonate. To maintain a concentration equilibrium between the RBC and the plasma, the excess bicarbonate diffuses out of the red blood cell. Once in the plasma, the bicarbonate combines with sodium, which is normally in the plasma, in the form of sodium chloride. The bicarbonate is then transported to the lungs as sodium bicarbonate in the plasma of the venous blood. As bicarbonate moves out of the RBC, the chloride, which has been liberated from that sodium chloride, moves into the RBC to maintain electric neutrality. And this movement of chloride into the RBC and out of the plasma is known as the chloride shift, or the hamburger phenomenon. In the plasma, the ratio of bicarb and carbonic acid is normally maintained at 20:1. This ratio keeps the blood pH level within the normal range of 7.3 to 7.35 to 7.45. carbon dioxide elimination at the lungs. Pictured here is figure 621 from page 297 of your book. This shows venous blood entering the alveolar capillaries, and the chemical reactions occurring at the tissue level are reversed. The chemical processes continue until the CO2 pressure is equal throughout the entire system. And then eliminated in the alveoli. Again, here are those CO2 transport mechanisms. In plasma, about 1% of CO2 is transported as a carbamino compound, or CO2 combined with protein. 5% is bicarbonate, and dissolved CO2 is about 5%. In the red blood cells, dissolved CO2 is transported to the lung as about 5%. Carbamino hemoglobin is about 20%, and bicarbonate is the vast majority, about 63%. Let's talk for a minute about the carbon dioxide dissociation curve. You can see that this curve is much more linear than our oxygen dissociation curve. In the carbon dioxide dissociation curve, the loading and unloading of carbon dioxide in the blood is illustrated in a graphic form. However, unlike the S-shaped oxygen dissociation curve, the carbon dioxide curve is almost a line, linear. This means that compared with the oxyhemoglobin dissociation curve, there is a more direct relationship between the partial pressure, or PCO2, and the amount of CO2, or CO2 content, in the blood. For example, when the PCO2 increases from 40 to 46 between arterial and venous blood, the oxygen content also increases by about the same amount. The same partial pressure change of oxygen would increase the oxygen content only a small amount. The level of saturation of hemoglobin with oxygen also affects the carbon dioxide dissociation curve. When the hemoglobin is 97% saturated with oxygen, there is less carbon dioxide content for any given PCO2 than if the hemoglobin were 75% saturated. The fact that deoxygenated blood enhances the loading of CO2 is called the Haldane effect. Note also that the Haldane effect works in the opposite way, that is, oxygenation of blood enhances the unloading of CO2. Thank you for your time and attention today, and I hope you have a wonderful day. This concludes our lecture on hypoxia and carbon dioxide transport for AP 118. Have a wonderful time.